Hello and welcome to another session, or our last session should I say, for PW2002. This morning we're going to look at adverse drug reactions. So, hi, there I am. So this morning we're going to look at our key objectives. So obviously so far across the module we've looked at a recap of the pharmacology. We've looked at some of the legislation, some of the policies, some of the other bits and pieces that we're going to use when we think about medicines management. We've then also looked at our self-administration of medication and how we can support our patients in doing this. We've also then, you've done your really good group work over the last couple of weeks and done some brilliant presentations for me, trying to show how your chosen medication links to the body systems, how it links back to the pharmacology, pharmacokinetics, pharmacodynamics within the body. And so today we're looking at our so we're going to look at our key objectives today are going to be adverse drug reactions. So by the end of this morning's session, or this recorded session, we're going to be able to explain the different types of adverse drug reactions which you might encounter, and you're going to be able to understand the principles behind why some of these adverse drug reactions occur. We were going to look at anaphylaxis as well, but I know a lot of people have done their own trust anaphylaxis training. So rather than trying to replicate anaphylaxis training that you may already have achieved or you've already done, I've put some resources on the OneNote notebook, on Blackboard, on Teams that you can access, that you can have a look through for your anaphylaxis. And obviously if you haven't completed anaphylaxis training and you feel that it might be beneficial to you within your role, you know, have a look on your intranet, have a look on your other things and try and book on an anaphylaxis training session, because obviously this is going to be really, really useful for you when you're thinking about your work-based learning hours later on towards the back end of the year. So if you haven't done it, it might be something that's worth penciling in for your work-based learning hours. So obviously a quick recap of some terminology. So obviously when we've been looking at our medications over the last kind of 5 or 6 weeks, we've been coming across things like therapeutic effect, and obviously this is our desired response to medication. We've looked, especially when we've been talking about our anticoagulants, and we've looked at different types of anticoagulant therapy. We've talked about medications that have a low therapeutic effect, a high therapeutic effect. So again, this is one of the things when we're thinking about adverse drug reactions, we've got to think about, you know, what is the boundaries of the therapeutic effect. We've also got to think about side effects. Obviously, you've all researched your side effects, you've looked at the side effects of your medications, but a side effect is any unintended effect of a pharmacological product occurring from a normal therapeutic dose and is related to its pharmacological properties. Such effects may be well known and even expected and require little or no change in patient management. So again, a side effect, these are the things that we expect to happen. You know, the big long list of things, I think we've joked about it over the last few weeks, you know, one of the main side effects of a paracetamol is a headache, but we're taking it for a headache. So it's, you know, these are the things that we're expecting. When we're thinking about our adverse drug reactions, we aren't actually thinking about a response to the medication which is expected. We're thinking about a response to the medication which is not expected. And the World Health Organization defines an adverse drug reaction as a response to a drug which is noxious and unintended, and which occurs at doses normally used in a man for the prophylaxis, diagnosis or therapy of diseases, or for the modification of a physiological function. So again, it's quite useful or interesting to think about, you know, we looked at gender and age and all those different things last week and how they might actually affect our medication use. But when you think about your World Health Organization definition, obviously here it's actually got the word man in. So thinking back to last week, or to the previous sessions that we may have done, and back into the sessions that we did within your first year meds management modules of 1002, you know, medications were historically tested on male subjects. So obviously it's really interesting that the World Health Organization has man in its definition. You know, they are expecting more adverse drug reactions in females or in patients that haven't necessarily been tested on these certain medications. Might be something when you're thinking about that learning outcome 3, when you're thinking about some of the ethics around your frameworks and your legislations, policies and procedures and things, think about that. That might be something that you want to mention or talk about, is the ethics of some of these things. Was your medication tested on a varied population, or is it a historical medication that was only tested really on male subjects, so we don't fully know whether or not we might have some adverse drug reactions within your subject use. So adverse drug reactions. So as we said, it's a reaction that is always unwanted by the patient. It isn't something that is beneficial, it isn't something that is good. 4% or approximately 4% of hospital admissions are associated with these adverse drug reactions, and about 70% of these adverse drug reactions can be considered as being avoidable. So we have to think about, what is happening? Why are our patients experiencing these kind of not wanted responses? So as we said, the epidemiology of this is 4% of hospital admissions. So as we've said, 1 in 1,000 deaths on medical wards. Now that actually sounds quite a low number in some respects, but actually if you think about how many patients might be on medical wards at any one time, 1 in 1,000 is actually quite a big number really. 10 to 20% of inpatients have some kind of adverse drug reaction, and 5% of all patients in general practice. So again, we're looking at some big numbers really when we're thinking about the impacts of adverse drug reactions on our patients. So some of the things, some groups of medications, if we're thinking about risks to our patients, so we've got, some of the groups of medications that we've been looking at over the last few weeks. So obviously we have our anticoagulants. We've talked about our anticoagulants quite a lot because quite a lot of you are looking at anticoagulants. I think there's quite a lot of clopidogrels and things going on there. So anticoagulants tend to have, especially if we're thinking about the warfarin, the heparins, the old vitamin K inhibitor type anticoagulants, these have a very narrow therapeutic index. So this means that if you're not right in the middle of that very, very precise therapeutic band for that particular patient, that the patients have potentials for clots, for bleeding. There's also high probabilities of interactions with other medications, especially if they are herbal medications, over-the-counter products. When you're thinking back to your different kind of legislative bans of your medications, patients might be taking things without asking for advice and support from practitioners. And also anticoagulants can react with food quite a lot, back to the whole grapefruit thing. So we've got injectable sedatives, so examples, midazolam, lorazepam, things like that. So obviously some of the adverse drug reactions that you might see with those kinds of medications are things like oversedation, or we might have hypertension, delirium, lethargy. Obviously we have our insulins, so obviously so many different types of injectable insulins out there, but some of the adverse drug reactions can include loss of blood sugar control, and this can be especially impactful in our post-operative patients, because again, they might have been starved for long periods of time. They may not, obviously if they're going for a longer surgery, they might have had an insulin pump that can be amended to support that. But if our patients haven't had an insulin pump hooked up to them during surgery, again, trying to achieve blood sugar control without causing hypoglycemia after surgery can be quite a big challenge because of the impacts of fasting on our patients with diabetes. Obviously opiates, there's a few of you doing opiates. So our opiates, adverse drug reactions that we might come across are things like sedation, respiratory depression. People can have big impacts upon their respiratory centres and cause problems with breathing. Again, confusion, lethargy, nausea, vomiting, constipation. So again, some of these may be like vomiting, constipation, itching isn't on there as well. Some are on the cusp of side effects, because, you know, we can expect some of these, but actually, you know, there are also adverse drug reactions. If we have patients who are on water tablets, so something like frusemide, you know, some of the adverse drug reactions from that can be things like hypokalemia, hypomagnesia, you know, they're making you pee a lot. So because of that, you know, you're getting rid of some of those key chemicals and key things that are within our blood makeup. So again, we can cause issues with that. Other long-term effects that can be associated with frusemide use are things like hyperkalemia, dehydration. Obviously, we all love a statin. So again, some of the adverse drug reactions that can affect our patients who are taking statins are things like tachycardia, hypertension, headaches, and also altered liver function. And obviously one of the things that we've looked at quite a lot is where our medications are metabolized. So if we're taking an oral medication that's metabolized within the liver, obviously a medication that may have an impact upon the liver and cause altered liver function might actually have a bigger systemic cause or a bigger systemic problem of adverse drug reactions with other medications as well. And then we have our paralysing agents. So obviously we've got an example here of suxamethonium. So again, these are the things that you might use within theatre, that you might use within surgeries or other things. So problems that we could have that are things like tachycardia, we might have arrhythmias, we might have bronchospasms, we might have prolonged periods of apnea. So again, you know, our patients need to be monitored very, very well if we're using any types of paralysing agents, to make sure that they're not going to have impacts upon their respiratory system for longer periods of time than expected. With things like suxamethonium, we can also have genetic conditions which can lead to a problem called malignant hyperpyrexia, and this is quite a severe adverse drug reaction. I mean, when I was in theatre, I think we saw it once, but it is such an extreme drug reaction that patients, especially if they have this genetic tendency towards malignant hyperpyrexia, that it is like an emergency situation, and this can cause hypothermia, tachycardia, hypoxia and acidosis, which obviously can have really bad long-term key problems for the patients and can also potentially cause death. When we're thinking about our adverse drug reactions, we can categorise them into 5 main really kind of areas. So we tend to call these the A, B, C, D, E categories. So we can have augmented effects, we can have bizarre effects, and these are the two adverse drug reaction families which tend to be the most key adverse drug reactions that we have to look out for. We can also have our chronic drug reactions, we could have delayed reactions, and we could also have end of treatment effects or withdrawal effects. Some of these can be seen most often with anti-anxiety medications, antidepressants. If you've got a patient who's on a serotonin reuptake inhibitor or an SSRI, you know, you can get things like serotonin syndromes, but we'll look at those as we go on through the PowerPoint. So your first type is type A, or augmented. So type A, at least 75% of all the adverse drug reactions tend to fall within the augmented category. And the reaction is an augmentation of the drug's pharmacology. So this means that type A can be subdivided into primary effects. So these can be predictable, so for example bleeding from excessive warfarin use, or to secondary effects, so examples such as antibiotics causing diarrhea. So again, they are things that we think about to some extent as still being in that side effect kind of category, but they aren't specifically side effects, they are adverse drug reactions. If these things are happening, obviously it's key to be recording these things within our patient's notes, report them back. We might need to therefore consider stopping the drug, alter the dosage, or switch to an alternative. Obviously this needs to be discussed with our prescriber and it needs to be discussed with the patient to see whether there is an appropriate alternative which can be used. The second type's bizarre. So this is unrelated to the dose, completely unexpected and idiosyncratic. We're not actually 100% sure where this particular adverse drug reaction has come from. It's not predicted and it's not dose related, as we've said. So our bizarre reactions tend to be things like allergies, tend to be things like anaphylaxis. Obviously, if we have a bizarre adverse drug reaction, it's really key that we stop that drug immediately. We need to prevent further serious complications, and it might be that emergency or prompt and rapid care is required. Obviously, if a patient is having an allergy or they've gone into anaphylaxis, it's really key that we follow appropriate policies or procedures and that we get the patients treated through whatever appropriate manner as quickly as we can. And again, record and report. These are really, really key that are, that we really have to do within our roles. So when we're thinking about these two types of adverse drug reactions, as we've said, these tends to be related to the pharmacology of the medication. So drug reactions can be described as being either pharmacokinetic or pharmacodynamic. See, I can't even speak this morning. Or pharmacodynamic. There we go. See, I can't say it. So pharmacokinetic, this is obviously affecting those 4 key processes that we all know and love by now: our absorption, our distribution, our metabolism, and our excretion. So adverse drug reactions within the pharmacology of our medication tend to be most commonly when medications are taken orally. So this is because many drugs and many medications can require very precise conditions for optimal absorption. As we said, this happens within the stomach. It can happen in the gastrointestinal tract. It might be that patients are taking their medications with food or without food. It might be that they're taking certain medications at the other time as other medications, so examples can be things like antacids can cause problems with the actual absorption of certain medications because of the antacids' effect on the ability of the stomach and the kind of duodenum, small intestine and things of actually absorbing the medication and other nutrients from within the bowel. So it could be distribution. So it could be that obviously you've all looked at your medication. We've talked about, whether or not our medications need to be bound to plasma proteins during their distribution through the body for them to actually be able to be uptaken by the cells, to be uptaken by the appropriate places. So the less a drug binds with these proteins within the blood plasma, if it's appropriate, the more efficient the drug is in diffusing and crossing cell membranes. So obviously, if we haven't got the optimal environment within our systemic circulation, this can actually cause problems with the uptake of medication, with either too much or too little actually passing to the appropriate places. This can actually be a key issue with babies. So plasma protein levels are very, very low immediately after birth, especially in premature babies. So obviously, if we're trying to get medications into premature babies to support them, this can be a big issue with adverse drug reactions because of the ability of these medications to bind with plasma proteins. It can also be a problem with any drug which is extensively bound to plasma proteins if there is an imbalance within the homeostasis within the systemic circulation. So obviously our next stage is our metabolism. So metabolism, some drugs can interfere with the effectiveness of a drug metabolizing enzymes in the liver. So obviously, as we've said, we've looked at medications that can affect liver function. We've looked at how liver function can affect the metabolism of different medications. So obviously, the 2 key areas how this can cause adverse drug reactions is that it could either be an enzyme inducer. So this could mean that the drug or the medication that's being taken actually increases the effectiveness of the enzyme and therefore metabolizes it more quickly. So this can mean that the effectiveness of other drugs and their duration of action might be increased. So we're actually making the bioavailability of our medication higher. If we're making that higher, there's more medication within the body that can be used. Or it could be the opposite, that we've actually taken a medication which is an enzyme inhibitor. So this is where the medication that the patient's taking can decrease the effectiveness of the enzyme and therefore metabolize it more slowly. Ooh, I've just realised I've got a Z in that metabolize. Ooh, I've gone all American on us all. So this means that the effectiveness of other drugs and their duration may be, and again, I have an error, that should be decreased, not increased. They don't both increase it. So an enzyme inducer increases the effect of metabolization, and an enzyme inhibitor decreases the effectiveness of metabolization. So I apologise for that last little sentence. I don't know why I went all American and wrong on us, but hey ho. So excretion. So obviously excretion, how we get rid of the medication out of our body. There aren't actually that many medications that have a dramatic effect on drug excretion. However, if we have a patient who's taking non-steroidal anti-inflammatories, so ibuprofen, things like that, this can actually affect the kidney tubule. So if you think back to our anatomy sessions when we looked at the anatomy and physiology of the renal system, and we went through, how the endocrine system affects the ability of our proximal and distal convoluted tubules to actually be able to reuptake the stuff that was squished out within the glomerulus. If a patient's taking a medication like ibuprofen, this can actually affect the ability of reabsorption. Therefore, we might actually be reabsorbing more than we should be, so we're not excreting it effectively, which again can cause toxic levels within the body. We can have pharmacodynamics, and we can have pharmacodynamic effects. They tend to be a little bit more common, and they only come in two main categories. So they can have additive effects of drugs which can cause similar actions, or there can be competing effects of drugs with opposite actions. So obviously this can be spread into good effects and bad effects. So bad effects, obviously we've got to start with the first one, that actually, even though we're taking our medication to help, all drugs could potentially be dangerous. However, on the counter of that actually, if we're using our medications properly, they might not be as dangerous. The most dangerous drugs can have the greatest potential for benefits. Think about your chemotherapy medications. They are absolutely devastating on the body. They're there purely and simply to kill quick growing cells, which is why obviously we have the reactions of losing your hair, having problems with mucous membranes. However, it's got the biggest beneficial, hopefully, effect in that, if it's killing all fast growing cells, it's going to affect the tumour cells. So obviously it's super dangerous, however it can actually have a massive benefit. Some drugs have a very low therapeutic range, so again it might be very hard to get the desired effect. Some drugs have a very low incidence of horrendous side effects. It's sometimes very easy to forget about the problems that patients might have with adverse drug reactions because some medications hardly have anything. Some drugs can be dangerous in acute poisoning, but not when used therapeutically. An example of this is, there are so many different examples. If you think historically about where we've actually got our medications from, there are so many different examples of medications that can be used within poisoning. However, we actually have used them for a really good therapeutic effect. You know, if you think about digoxin, used to manage heart rate, it's developed from the digitalis, sorry, brain going, which is the name for foxglove. But obviously they used to be used as a poison, because if you gave a patient or a person or somebody random crushed up foxglove flowers, it could actually induce heart attacks. So you could actually use it as a poison to actually kill somebody. But obviously they looked into this and they looked at the therapeutic effects and actually found that it could be helpful when we're thinking about the maintenance of our heart rate. So some adverse drug reactions can be predicted if we actually understand the pharmacology of our medication. These can be things, examples of type A. So if you think about our augmented effects. However, because when we thought about our bizarre effects, these are just completely out of the ordinary. Obviously, it's a lot harder to actually understand whether or not a patient is going to have a bizarre effect or a bizarre drug reaction to our chosen medication. And some adverse effects occur after a delay, or they may even occur after we've actually stopped our medication. So again, it can cause issues for our patients. And finally, how dangerous a drug actually can depend on the skill of the prescriber. Has the prescriber fully understood the medication? Do they know why they're prescribing it? Have they looked at the full history of the patient? Are they aware of anything and everything that a patient might be taking? You know, it's really key that our prescriber has a full medical history, has a full diagnosis, has a full understanding before they actually prescribe our medications, because as it says at the top in red, you know, actually all drugs are dangerous at the end of the day, and they just have to be used appropriately. So following on from this, you know, the prescriber has to think about the risk to benefit ratio. So when prescribing drugs, a doctor or a prescriber, whoever's actually having that influence on the prescribed medication, must assess the risk-benefit ratio in an individual patient. So they tend to do this by choosing an appropriate class of drug and then an appropriate agent. So they've got to ask themselves, you know, is this medication going to be effective? What are the chances of our patient having an adverse effect? So are there any features in this patient which could affect the choice? So are they taking any other medications? Do they have any issues with organ failure? You know, thinking back to, do they have any liver issues, any kidney issues? You know, what's their age? Are we aware that actually there's more problems if we're taking it as an older patient? It's really key that they also tailor the dose to the patient that's in front of them. And they need to think about the duration of the treatment. Again, you know, is this a medication that the patient's going to be on for the rest of their life? Is it a short-acting medication that they're taking, for example, you know, a short course of antibiotics? You know, as we've said previously, you know, we tend to be dealing with patients who are in the more older adult age bracket. So when we're thinking about this, our adverse drug reactions can have more effects, or they tend to present more often when we're dealing with our older patients. And some of the reasons tend to be, you know, some older patients, when we're thinking back to our self-administration of medication, when again, we can link it back to our learning outcome 3 for our ethical things, we can link it to our learning outcome 4 for our self-administration of medication. You know, sometimes it can be because our medications are taken erratically. You know, our patients aren't taking them as prescribed, they're not taking them at the right time, they forget to take them, and this can cause problems with our therapeutic dosages. It might be that they've actually got multiple pathology. They might be dealing with patients with comorbidities. So again, this can actually have a cause a problem with our patients. It might be that they, because of they're older and because they've got these comorbidities and because they've got problems maybe with their renal system or hepatic system, that they have an altered pharmacokinetics within the body. So again, how it's back to, you know, absorbed, metabolized, distributed and excreted. Or they might actually have an increased sensitivity of their central nervous systems and cardiovascular systems. So again, these can all cause problems that are going to make adverse drug reactions a lot more observed within our elderly or older patients. Okay, so when we're thinking about our adverse drug effects, it's really important that we think about how these medications are actually kind of detected. So if a new drug causes a bazaar, so bazaar, remember, are our drug reactions that are completely unexpected, in 1 in 6,000 patients, it would need 18,000 patients to use this medication for it to occur in 3 patients. It would then take at least twice as many as this to actually report some of these medication adverse drug reactions for them to even start to suspect that any of this effect might be due to the drug. You know, if the effect also occurs naturally, then it would take even more times patients. So if we're talking about nausea, if you're talking about vomiting, if you're talking about itching, if you're talking about some of the more minimally invasive for our patient adverse drug reactions, it's really, really key that we're thinking about, you know, are these reactions actually going to get reported? So when you think about the fact that actually we need to be having a good 40,000 patients taking a particular medication, reporting back on any weird and bizarre kind of side effects or reactions before we'd really start to get a feeling for whether or not this medication is appropriate. However, most early drugs trials only involve around 2,000 patients max. You know, so it's really easy to see when you look at this how medications can get through, can get into the general population and into prescribing without us actually fully knowing whether or not they're safe. And it's really interesting to think about our adverse drug reactions when we're thinking about what's going on now and the development of a vaccine for COVID. Because, you know, we might get vaccinated with an amazing vaccination, but actually would we know if there were going to be any adverse drug reactions for us as patients before it's actually been rolled out, because of kind of the such focused effect on trying to get COVID, you know, contained and controlled. And when we're thinking about our adverse drug reactions and we're thinking about our roles and responsibilities within detecting these adverse drug reactions, there are quite a few things that we can do to help support us with this, that we can take forward and that we can use as tools. So obviously we have our legislative bodies. So obviously we have the MHRA, the Medicines and Healthcare Products Regulatory Agency. You know, you've looked at those previously. They have a free phone service for reporting any information or finding out information about any suspected ADRs. We have self-reporting by patients and relatives using the yellow cards, which are in the back of the BNF, and I'll identify these over the next couple of slides. You know, but patients can go in, talk to their pharmacists, and then these can be reported. It might be picked up when we're thinking about our medication reviews. It might be that a patient just says, oh, this happened, or this is, you know, I felt a bit iffy after this, or however they describe it. And it might be that you can trace this back to actually an adverse drug reaction and it's been picked up in a medication review. It might be that as a prescriber or as an administrator of medication, that we're aware of which are new medications, which are the ones that we need to maybe monitor, And we're looking for things like black triangles, and we're looking for any other yellow card information that might be available on the website. And it's also thinking about, our established drugs. Are we aware of what adverse drug reactions may occur in the established medications that we might be dealing with or our patients might be using? So as I said, one of the key things is our BNF. Obviously, our BNF, this is an old image, but our BNF all has on the back of them, they tend to have this little box that tells you, don't forget to think about identifying any adverse drug reactions using the yellow cards. I'm trying to just think if I have my BNF here. Again, the yellow card warnings on the bottom of the BNF. It should be on the bottom of all BNFs to say, don't forget, use the yellow cards, go on the website, make sure that you're reporting any adverse drug reactions so that this can be looked into really, really well. You can also, as it says here, you've got the BNF website. So again, you can also report any adverse drug reactions on the BNF website directly. But there'll be a policy, there'll be a procedure. You might have to do yellow cards in a line with, I've forgotten the name of the reporting form. It's gone completely. But, you might have to use one of the completing forms that you've got to do. So, have a think about that. Look at your policies, looking at your procedures for the reporting of adverse drug reactions in your patient groups. So obviously this is what the yellow card looks like. You need your suspected drug, your suspected reactions, what's actually happening to that patient. And then on the back, are there any other medications that the patient's on? Anything that's key that you might need to report so that they can actually investigate this in a little bit more detail. Other key things that you might come across, and some of the key pieces of reporting information really that patients might have reported are some here on this sheet from historical data. So across the years, I think this covers 1995 to 2005. So we've had issues. So again, we've had quinoline antibiotics. So this can cause tendinitis and tendon rupture. So they've changed that by putting better actions on and improved warnings. Tramadol can have psychiatric reactions. So again, they've put warnings on. We've got, I'm trying to look at other ones that we might have heard of. Again, there's one there for if in 1999 there was Astrachia, a Chinese herbal remedy. So again, it wasn't even a direct medication, but because this can cause severe renal failure, it was actually banned. So again, with warfarin, can interact with cranberry juice. So they've put improved warnings on our medication with inpatient information leaflets, and obviously more monitoring recommendations. And rovastatin can cause rhabdomyolysis. So obviously they've put better warnings on the package. They've looked at revised dosage instructions. So again, it's really key that some of these things are actually, they are followed up, they are supported, they are actually, moved forward. It might take time because they've got to actually identify these in enough detail to be able to pinpoint what medication or what it is that's causing the adverse drug reaction. Was it just a weird and wonderful, bizarre effect that affected one patient? Or is this actually something that we've got to think about on the grand scheme of things for our patients across the board? So obviously thinking back, as we mentioned earlier, we've got our Medicines and Healthcare Products Regulatory Agency. And the Medicines and Healthcare Products Regulatory Agency is the government agency that's responsible for ensuring that medicines and medical devices work and are acceptably safe. So you can also report it to their website as well if there are any drug reactions or anything, click on the government, click on the MHRA, and have a look around there on, you know, what their reporting procedures are like. You know, there's lots of information on their websites, just like there is on the BNF, which are going to talk you through, you know, the key things, the key aspects that they've actually had reported over the years and how this has impacted changes going forward. So anybody can actually report to the MHRA. It's obviously really important that you use your hospital policies or trust policies and procedures. You know, when you're thinking about your area of work, is there a specific person who has the responsibility to do these reports? Or is it actually the practitioner who comes into contact with that particular issue? But the MHRA actually reports that on average, it's estimated that 94% of practitioners actually underreport. And they have a really good ability and activity at detecting adverse effects. However, that we don't have a very good way of assessing the risk ratio. So it's really, really key to think about, you know, who's actually reporting these things, who's, you know, making these contacts, making people actually aware. And you can see from the little pie chart we've got here that patients were reporting about 13% of the time, pharmacists were about 12, GPs were about a quarter, and then obviously the other half was pretty much, you know, healthcare practitioners within the hospitals, within other settings. So we have our other healthcare professionals, nurses, hospital doctors, etc. So when we're thinking about our medications, you know, how do we actually reduce the risk of our patients having an adverse drug reaction? So I think the first thing is that do we know what the medication is, how it should be used? Is the patient aware of all that information? Do we know where to find it? But some key things to think about are examples like, you know, don't crush enteric coated sustained release tablets. If we crush them, we've just kind of made the whole sustained release enteric coating mute. It's pointless. If a medication's in a capsule, don't open it. You know, we shouldn't be decanting contents of capsules into something else, because again, it's going to affect the absorption of that particular medication. You know, we need to make sure that our patients are aware of foods or drinks that may actually increase the risk of actually having an adverse drug reaction. We need to make sure that they've been correctly stored and handled. You know, think back to your learning outcome 1 for this assignment. You know, what are the policies and procedures and legislations around the correct storage and handling of our medications? How is it that we need to do it? You know, if it says keep out of direct sunlight and a patient has them stored on a windowsill, that could actually denature the medication. If it needs to be kept in a fridge, it needs to be kept at a certain temperature. Again, are our patients aware of this and aware of how to keep their medications safe? We need to make sure that our patients have regular medication reviews. So again, that practitioners are aware of what our patients are on, what they're being prescribed, and how they might actually increase or decrease risks. We also need to consider the characteristics of the individual. You know, we need to think about the age, the genetics, and the liver and renal functions of our patients, because if there are anything that's happening there, it could actually increase the patient's risk of having an adverse drug reaction. You know, if we're diluting our medications, if we need to mix them with things, are we actually using the correct dilutants? We need to ensure that our intravenous fluids are protected from light, heat and cold, that they're stored appropriately. Again, going back to that learning outcome 1, going back to those legislations, policies and procedures on the safe storage and handling of our medications. And then we need to check that nothing is actually being contaminated. Obviously, this is specifically important for our intravenous fluids that are going directly into the circulatory system. But it is really key that we think about, you know, if a patient is having an injected medication and we have to draw it up, Are we using filter needles, if that is appropriate, to reduce the risk of any tiny glass shards from a broken vial actually being injected into the patient? So it's really key that we think about, when we are working within medicines management, that we think about the key aspects of this to support our patients in their reduction of adverse drug reactions. We can also think about, we never use any drug unless there is a good indication. Has it been prescribed? Has the prescriber thought about everything? As we've said previously, we don't know what is happening within the unborn fetus. Do these medications actually cross the placental barrier? Is it going to have any direct effect on the development of the fetus? So again, if a patient is pregnant, think about, do we have to use any medications? So not using a medication unless the need is imperative. Again, when we're thinking about bazaar, we're thinking about, allergy and idiosyncrasies are important risks and causes of adverse drug reactions. So it's really, really important that when we are getting a patient history, that we ask if the patient has ever had any previous reactions. Is it something that we have to be aware of in the medication that we're giving the patient? And it's also the key that we need to ask if the patient's already taking any other medications, including self-medication, over-the-counter medications, herbal remedies, anything weird and wonderful and random that it may have an impact upon whether our patient is going to have an adverse drug reaction. So again, we're nearly there, don't worry. I know it's been a long one today. But obviously the last couple of things that we have to think about is, our patients, again, like we've said earlier, their age, their hepatic and renal diseases, anything like this may actually impair the clearance of drugs. So actually smaller doses might be needed because we've got more bioavailability. They're going to stay within the circulatory system for longer. Genetic factors may also predispose certain patients to adverse drug reactions. So like we said before, if there is a genetic familial trait of malignant hyperpyrexia, even if a patient has never reported having or suffering from malignant hyperpyrexia, the anaesthetist would be a lot more aware of, the risks of using certain medications and stay away from them, because obviously they don't want to risk any adverse drug reactions. It's key that a prescriber prescribes as few drugs as is possible, and that the patient or carers, relatives, anybody who's dealing with that medication is given clear instructions. As a prescriber, it's really key that you use, where possible, drugs that you're familiar with. If you are moving on to new medications, if you are using medications that have only just come out, keep yourself up to date and alert for any new adverse drug reactions or any new unexpected events that you might or your patient might experience, and then report them promptly. And if any serious adverse drug reactions are liable to occur, make sure that the patient's aware, they know what to look out for. We have a duty of candour with our patients. If we know that something serious has a potential to occur, we can't just go read the leaflet. We have to make sure that that patient is fully informed, that they're aware of what's happening, why it's happening, and what the risks are, for them to make that fully informed choice. And finally, I can hear you all going, yay, in the background, but finally, the role of the practitioner is minimising the effects of our ADRs. So obviously it's really key that we recognise any previous allergic reaction. Talk to your patient, communicate. Is there anything that's ever happened to them before? That we're identifying drugs with known side effects and that we're trying to select a safer alternative. That we're checking that patients aren't exposed to any unnecessary risks. That we're providing information regarding the correct use of a drug. That practitioners must have a sound knowledge. Don't be using or prescribing medications that you're not aware of, that you don't understand. You know, it's really key. You know, you've done your medicines management modules now, you've been looking at this, you've been developing your knowledge of our medications. If you're working with medications, find out about them, read the BNF, get advice, you know, tell the nurse, you know, or sorry, the patient may tell them or tell you any problems or any side effects or any issues that they've experienced before. So it's really, really key when you're thinking about it to make sure that you're aware of what your medication does and what your medication might cause so that you can see whether or not it's an issue. You know, monitor your patients. And lastly but leastly, report and document. So obviously that was today's fantastic, I know you all thought it was brilliant, ha ha ha, yeah, right, PowerPoint on adverse drug reactions. So as I said, I'm going to put the anaphylaxis stuff in all the appropriate places. So have a look at that. I'll get your tasks for today on as well, so have a look at them. And we will get together for our meeting at 1 o'clock like normal. Other than that, have a great day, enjoy working through the tasks, and I shall see you this afternoon. Bye!